John, how far out do you have these scheduled?
I think Audrey's on the call. I think we're actually out through October now.
Oh, great.
That's correct.
Good.
If anyone's interested in presenting a topic, we'd love to have you.
Okay.
Yes, very much so. Good afternoon. Hi, it's John Snyder here with Thursday afternoon. We have another edition of Lunch and Learn today. We are experimenting with a little bit of new technology today as the Zoom meetings have changed. So bear with us if you've been in the waiting room. We're working on that system. Today we have a pleasure of hearing from Dr. Sita Raman, who's one of our endocrinology specialists here at Newton-Wellesley Hospital and at the medical group. And she's going to be talking to us about the treatment with SGLT2 inhibitors. And as always, there is CME available for this. You can put that code in. I'll make sure I put that code into the chat box, ROYPOI. And also want to tease next week's Lunch and Learn dermatology update with Dr. Pam Weinfeld and Dion Wolpowitz. And as you know, again, CME credits are available. And we're also very excited that we are recording these sessions, and all the sessions are posted up on YouTube. And you can find these sessions by just going to the search bar and searching Newton-Wellesley Medical Group Lunch and Learn. And then all the sessions will come up, and I've tried that myself. I'm going to allow Dr. Sita Raman to take over here as she grabs the slides. And I appreciate everyone joining us in this last week of August. I know it's been a pretty unusual summer, and we will continue to go right through next week and the following week. Dr. Sita Raman's going to talk for approximately 20-25 minutes and then take questions at the end. If you have questions or cases you want to have her present, please put them in the chat box. We'll read them off at the end. Kavita, you okay grabbing the screen?
Yeah.
Go ahead. Perfect.
Is the audio clear?
Perfectly clear. Keep going.
Good afternoon, everyone. Thank you, John, for the introduction. It gives me a great pleasure to give a talk on this important topic, SGLT2 inhibitors, a collaborative approach to patient care. The talk will convey the following messages. SGLT2 inhibitors lower the risk of major adverse cardiac events, cardiovascular death, heart failure, hospitalization, all-cause mortality. We will highlight the importance of selecting ideal patients for treatment with SGLT2 inhibitors and emphasize the importance of collaboration across medical teams. The talk will begin with a clinical scenario, followed by a brief discussion about SGLT2 inhibitors and their discovery. I will then dive into the basic aspects of renal physiology to understand their mechanism of action. I will then explore the pathophysiology of heart failure and discuss the impact of SGLT2 inhibitors in those with and without diabetes, discussing some of the cardiovascular outcome studies with SGLT2 inhibitors. I will then review a collaborative approach and discuss safety aspects to consider while prescribing SGLT2 inhibitors for our patients. Ms. AM is a 62-year-old lady with type 2 diabetes, hypertension, hyperlipidemia, heart failure, and chronic kidney disease. She takes metformin, glipizide, Lantus insulin, and she returns for a follow-up today. Her hemoglobin A1C is 9.3%. Other medications are lisinopril, metoprolol, simvastatin, furosemide, the dose of which was recently increased after hospitalization for heart failure. On exam, she has 2+ lower extremity edema, 1+ fetal pulse in both feet, and impaired monofilament testing. Her labs are notable for proteinuria and chronic kidney disease. While I'm with Ms. AM in the clinic, the decision cycle for glycemic control comes to my mind. It's important to review every aspect of this cycle for successful outcomes. I first assess key patient characteristics and then consider specific factors that impact choice of treatment. And then I arrive on a shared medical decision platform, which I implement with SMART goals and then follow through. When we see patients with diabetes, it's important to focus on goals of care that is to prevent complications related to diabetes and to optimize their quality of life. In the pre-insulin era, the complications related to diabetes was famine and death due to undernutrition treatment. Subsequent to the invention of insulin, people began living longer. We since then have realized that diabetes is a chronic health condition associated with significant mortality, morbidity, hospitalizations, and healthcare expenditure. It's one of the leading causes of lower extremity amputations, blindness from retinopathy, chronic kidney disease requiring renal replacement in the form of dialysis and transplant, and accounts for significant cardiovascular morbidity and mortality. There have been discovery of several new therapeutic agents for management of type 2 diabetes over the past 15 years. Therefore, the glycemia management guidelines have also been changing every few years. Always think about the patient in front of you. And this is the most updated guidelines by American Diabetes Association. For my patient who has heart failure with reduced ejection fraction and has chronic kidney disease and type 2 diabetes, I opt to discuss SGLT2 inhibitors. The discovery of SGLT2 inhibitors dates back 178 years. Florizin from the bark of apple tree was discovered by French chemists in the year 1835. Subsequently, a German scientist by name Joseph von Mering in the year 1886 showed that florizin actually caused glucosuria. It was 100 years later that scientists began realizing that there is uniqueness to transportation of glucose in the kidney. Subsequently, SGLT1 and SGLT2 co-transporters were invented in the year 1990s. And in the year 1995, it was shown that florizin inhibited these co-transporters SGLT1 and SGLT2. Yet florizin was not an ideal candidate for management of type 2 diabetes because of its limited oral bioavailability, its non-specific inhibition of SGLT1 and SGLT2 co-transporters that resulted in malabsorption of glucose in the intestine, leading to diarrhea and dehydration, and floridin, an end product of florizin that caused suppression of GLUT transporter that resulted in poor uptake of glucose. This led to the invention of florizin analogs, today otherwise known as SGLT2 inhibitors. As you can see here, several of them have been since then discovered. In the year 2008, Dapagliflozin was the first SGLT2 inhibitor to have been first discovered, and it was approved in Europe for treatment of type 2 diabetes in the year 2012. Dapagliflozin was approved in the year 2013 by the FDA in the United States for management of type 2 diabetes, and in the year 2014, empagliflozin. Each of these molecules are very unique, and it's interesting to note that they differ based on their SGLT2 inhibitory activity. Empagliflozin, otherwise known as Jardiance, has the highest level of SGLT2 selectivity compared to others. Let's take a brief look into renal physiology to understand the mechanism of action of SGLT2 inhibitors. The glomerular capillary system is very unique compared to our normal capillary system in the sense that it has an arteriole on the afferent side and an arteriole on the efferent side, compared to a capillary system where there is a capillary and then there is a venule. Therefore, the pressure in the glomerulus is much higher than a normal capillary pressure, which results in glomerular filtration. And the glucose that is filtered through the tubules is reabsorbed in the proximal segment by the SGLT2 co-transporters. 90% of it is reabsorbed, and the SGLT1 reabsorbs the remaining 10% in the S3 segment of the proximal tubule. What happens in diabetes? There is increased intraglomerular pressure resulting in hyperfiltration of glucose and sodium. But at the same time, there is excess expression of SGLT2 and SGLT1 co-transporters in patients with diabetes. Therefore, there is increased reabsorption of glucose and sodium in the proximal tubule with decreased solute delivery, that is sodium delivery to macula densa at the juxtaglomerular apparatus level. This results in activation of renin-angiotensin pathway that causes efferent arteriolar vasoconstriction. So the glomerulus in type 2 diabetes is almost like a water balloon where one end of the hose is very tight and closed, and the open part, the afferent part of it is constantly filling, and the intraglomerular pressure is high, and this results in hyperfiltration, kidney damage, and the process continues. It's a vicious cycle. When we introduce SGLT2 inhibition, there is decreased reabsorption of glucose and sodium that happens in the proximal tubule. This results in increased sodium delivery to the macula densa, which in return results in increased ADP generation that causes afferent arteriolar vasoconstriction. Now you can see that the intraglomerular pressure is decreased, there is normalization of GFR, and there is reversal of this entire phenomenon, irrespective of whether the patient is on ACE inhibitor or ARBs, which work mostly on the efferent arteriolar pathway. This is in addition to the metabolic effects that we know about SGLT2 inhibitors. I'm not going to go into the depth of this given the limited time. It's well known that cardiovascular disease is the most common cause of mortality in patients with diabetes. However, several of the prior studies have failed to demonstrate significant reductions in macrovascular disease, particularly cardiovascular mortality and heart failure hospitalizations with intensive glycemic control. When rosiglitazone was found to have a possible association with increased myocardial infarction and cardiovascular death, FDA mandated that all of the new glucose-lowering medications first demonstrate cardiovascular safety. Subsequently, in the year 2015, the EMPEREG study was published in New England Journal of Medicine. And in this study, patients with type 2 diabetes and cardiovascular disease, pre-existing cardiovascular disease, were given empagliflozin in addition to standard of care. Empagliflozin reduced the risk of 3-point major adverse cardiac events by 14%, cardiovascular death by 38%, risk for heart failure hospitalization by 35%, and all-cause mortality by 32%. Subsequently, canagliflozin in the CANVAS study was studied, and dapagliflozin in the DECLARE-TIMI study was studied and published respectively in the year 2017 and 2015. Each of these medications proved non-inferiority to placebo and also possible benefits towards reducing heart failure hospitalization and progression of chronic kidney disease. Specifically, let's now take a look into heart failure. Heart failure is highly prevalent in patients with diabetes. Patients with diabetes and without heart failure have a higher risk of developing heart failure. And patients with the two conditions, that is diabetes and heart failure, have a higher risk of mortality compared to patients without diabetes or heart failure. Heart failure is a progressive condition. Patients progress from stage A to stage D and it is not reversible. The 5-year survival in stage A is 97%, whereas the 5-year survival in stage D is only 20%. When we see patients in the clinic, we often categorize them based on New York Heart Association classifications, class 1 to class 4. But you can see here that someone in class 4 can reverse to class 2 or class 3 to class 2 based on treatment. Whereas we should always keep in mind that this staging doesn't reverse. And it's important to highlight stage A. These are patients who are at high risk for heart failure, but without structural heart disease or symptoms of heart failure. And these pretty much include all of our patients with diabetes, hypertension, or coronary artery disease. In the EMPEREG study, a subset analysis indicated the benefit of empagliflozin for type 2 diabetes patients with and without heart failure, and regardless of those at high risk of heart failure, whereas at low risk of heart failure. And similar efficacy was demonstrated with cardiovascular deaths as well, regardless of their cardiovascular underlying risk factors and pre-existing cardiovascular disease. Let's look into the underlying mechanism by which SGLT2 inhibitors help in heart failure. For this, I'm going to review pathophysiology of changes that happen in heart failure. In diabetes, there is glucose toxicity resulting in coronary atherosclerosis. In heart failure, there is also activation of adrenergic pathway, renin-angiotensin system, and increased insulin resistance resulting in inotropism, vasoconstriction, leading to endothelial stress from release of inflammatory cytokines and reduced nitrous oxide production, resulting in mitochondrial damage, myocardial fibrosis. Healthy heart and myocardium utilizes free fatty acid for generation of ATP. This is by process of beta oxidation of free fatty acid. Under situations of hypoxia and wall stress, this pathway is shifted to glucose catabolism, resulting in generation of pyruvate and lactic acid leading to cell death. When we introduce SGLT2 inhibition, The energy-deprived heart derives its energy from the ketones generated by SGLT2 inhibitor treatment. Ketones are excellent substrates in situations of hypoxia, stress, and in situations where the free fatty acid cycle is suppressed. Therefore, an energy-deprived heart becomes energy-repleted, and there is improved cardiac function. This is in addition to the beneficial effects from diuretic effects leading to natriuresis, glucosuria, increased glucagon production, and also we talked about the ketone body generation. Therefore, one can conclude that CV benefits of SGLT2 inhibitors are independent of their effect on blood glucose control. With indications from each of the prior studies that I discussed that SGLT2 inhibitors have a positive effect on CV health in heart failure, the DAPA-HF study was launched in November of 2019. 4,744 patients with New York Heart Association classification, class 2 to class 4, and an ejection fraction of 40% or less were randomized to receive Dapagliflozin 10 milligrams once a day or placebo, in addition to the recommended therapy. Primary outcome was worsening of heart failure measured by hospitalization or an urgent visit to receiving intravenous treatment for heart failure or cardiovascular death. Primary outcome was noted in 16.3% of the patients with Dapagliflozin group compared to 21% of the placebo group. Secondary outcomes were cardiovascular death 9.6% in the DAPA group versus 11% in the placebo. Heart failure hospitalization 9.7 with DAPA versus 13.4 with placebo. And the overall effect was 30% risk reduction of worsening of heart failure, 18% risk reduction in CV mortality. It's noteworthy that absolute benefit of Dapagliflozin was greatest in the most elderly population, age over 75 years, who are at absolute high risk of developing heart failure hospitalizations. And also important to note that only 42% of the patients in the study actually had diabetes. The remaining did not have diabetes. Primary endpoint was nearly identical at different levels of A1C among patients with and without diabetes. Dapagliflozin was also noted to be associated with reduced new onset of diabetes by 32%, with 4.9% of the patients with DAPA group developing diabetes compared to 7.1% in the placebo group. Therefore, treatment with SGLT2 inhibitors involves a novel clinical care delivery model system that are collaborative and multidisciplinary, as we are catering to a very high-risk population, and the goals of treatment is to improve survival and quality of life. It starts with primary care physicians identifying patients with heart failure with diabetes, without diabetes, cardiovascular disease, chronic kidney disease, and optimizing their glycemic regimen and analyzing, are they on the appropriate treatment to improve their survival and quality of life? And considering referral to specialists, the team you can call as cardiometabolic team, including the endocrinologist, cardiologist, and nephrologist. And once patients are referred to the specialist, there is a constant cross-collaboration between each of these specialists along with the primary care team, with ultimate goal of successful outcome in improving patients' quality of life. In fact, this should be considered as a quality initiative pilot to identify those patients with heart failure with and without diabetes to discuss whether they are suitable for treatment with SGLT2 inhibitors, similar to how we approach optimization of statins or ACE inhibitors or ARBs. And ultimately, for successful outcomes, patients should be hearing a collaborative voice. Other factors to keep in mind are patients treated with SGLT2 inhibitors are at a slightly higher risk of urinary tract infection and genital infection. Important to educate patients on these side effects so that they approach their medical team for treatment in a timely manner. They are also at a higher risk of a complication called euglycemic ketoacidosis. Therefore, counseling on how to prevent this symptom, this complication is very important. I typically educate my patients not to take SGLT2 inhibitors on the days when they are sick with dehydration, diarrhea, flu-like symptoms, or if they are planning on fasting, either intermittent fasting for weight loss or for religious purposes, or if they are planning on surgery. And I also educate them not to discontinue insulin abruptly without discussing with their primary team which could be the primary care physicians or endocrinologists, as this could predispose them to developing excess ketones. It's worth considering at the start of initiating SGLT2 inhibitors to think about whether patients are insulin replete or depleted. And you might also want to consider testing a C-peptide to further support your answer. In the Canvas study with Dapagliflozin, there was a slightly higher risk of amputations noted on the foot. And this was mainly in those patients who had prior history of amputations, cellulitis, peripheral artery disease, and neuropathy. This graph is very interesting to demonstrate GFR changes that happens in patients with SGLT2 treatment. Within the first 2 weeks, there is a decline in the GFR, followed by a steady increase in GFR and improvement of kidney function in those treated with SGLT2 inhibitors. In fact, the doubling of creatinine was lowered by 44%, and the need for renal replacement was lowered by 55% in the EMPEREG study. And therefore, it's also important to keep in mind when you're going to test a basic metabolic profile, perhaps not in this 2-week time frame, where people see the decline in GFR and panic about discontinuing SGLT2 inhibitors when it is not necessary. The STITCH protocol, which was put forth by Dr. Satish Garg and Ann Peters, is very useful in educating our patients as to what to do when they develop euglycemic ketoacidosis. Euglycemic ketoacidosis is a situation that happens in patients who are treated with SGLT2 inhibitors and are not having adequate insulin in their system. The blood glucose is often normal because of glucosuria, but they develop ketones, and the ketones are not measured in the urine because the SGLT2 inhibitors slow the excretion of ketones. And therefore, it is important to educate these patients on measuring blood ketones if possible. Importance of this should also be conveyed to ER physicians and ourselves when we see patients with this concerning problem. The treatment is stopping the SGLT2 inhibitors and injecting a bolus of insulin and consuming 30 grams of carbs right away and encourage hydration. The key messages that I want to convey with this talk are as follows. Intensive glycemic control is not the sole driving factor, just focusing on A1C alone in improving cardiovascular outcomes in patients with diabetes. Judicious patient selection for treatment with SGLT2 inhibitors is critical. Educating patients on the fears and what to expect, when to titrate insulin, and other medications that they are on for management of their CV, health, renal, and heart failure management is key. Educating patients on sick day management and having a close follow-up is extremely important. Treatment with SGLT2 inhibitors involves a multidisciplinary collaborative effort, and it can apply to those with heart failure, with and without diabetes. Thank you.
Thank you, Kavita. That was excellent.
Thank
The
you.
whirlwind. Appreciate it. If anyone wants to kind of unmute themselves and ask a question, I don't see anything in the chat box for now. I was interested to see, and I guess I wasn't aware that these drugs have an indication for heart failure alone with or without diabetes. Is our cardiovascular team now traditionally using that in that setting?
I cannot answer specifically for the cardiologist, but I have been working with several of our team cardiologists and also Dr. Matter with nephrology. When I see patients and discuss about use of SGLT2, specifically if they have heart failure, I've had some of our cardiologists approach me to consider treatment with SGLT2 inhibitors, particularly in those with diabetes, but I'm not sure what the protocol is yet for those without diabetes and if they are starting them to treat on SGLT2 inhibitors. But clearly there seems to be a non-glycemia related outcome in these patients, which is beneficial.
Thank you. There's a question from Dr. Panesian. Could you discuss GLP-1 agonists such as Trulicity as an alternative, as this patient already on insulin, and this would be a once weekly injection? Would you still give cardiac benefit and no adjustment for renal function or CHF?
Yes, so this is an excellent question. And when you look at studies with cardiovascular outcomes and heart failure hospitalizations, GLPs have not shown that significant degree of benefit compared to SGLT2 inhibitors. particularly in improving outcomes with heart failure. And therefore, the American Diabetes Association, in fact, recommends selecting SGLT2 inhibitors for those with heart failure, chronic kidney disease. And the new DAPA-CKD study that is going to be published in October of this year at the American Association of Nephrology meeting is going to talk about how safe these medications are, even in those with GFR as close as up to 26. And therefore, we are going to have better options for patients with managing glycemia, with advanced kidney disease, and also heart failure. So my choice specifically to answer your question would be to first improve this patient's morbidity, survival with regard to heart failure. As you can see, they progress so much from stage A to stage D that you really want to add a medication that is going to help them in improving their cardiac function.
Thank you very much. Any other questions from everyone? We have 2 or 3 more minutes. Kavita, why don't you tell folks about your practice and where you practice and how long you've been here?
Oh, sure. I practice with my colleagues, Dr. Slovic, Dr. Stepel-Resnick, Dr. Laila Yasa, Elise Raymond, and our fantastic team, Melinda Rodriguez, Ian Sim, Heidi, Melissa, Sandy McKay, and our entire team, our crew at the hospital with the diabetes clinic. And we are called the NGH, Newton-Wellesley Hospital Endocrinology Group. I belong to Newton-Wellesley Hospital. So that's where our practice is located, and we see a whole panel of endocrinology diabetes related problems. The diabetes division is led by Dr. Stepel-Resnick, and Dr. Slovic is our chief. We have a very hardworking supporting team. And particularly, I would like to, say how spectacular our department has been functioning during this COVID times, where our patients with diabetes who specifically need all that support and what happens next and how they're going to manage in terms of their job and their families. Diabetes is a social problem, as you can imagine. And the amount of support our department and our staff has been providing for patients is just simply spectacular, and I'm so thankful for that. And we can be reached by e-consults. Dr. Yasa and myself address most of the e-consults. I've joined the team recently for this, and we are constantly available for referrals. I'll open the door for Dr. Slovic to add, if you have anything more to add, Dr. Slovic.
I think that was a fantastic talk. It really was wonderful.
Thank you.
As you mentioned at the end, it really is a team effort in dealing with diabetic patients. And it's been quite a challenge, and it's been great to have that team during these COVID times. The one last thing is that Dr. Sethuraman joined us both as a primary care physician and as an endocrinologist, and now is doing all endocrine. So she's part of the primary care group also, at least historically, when she joined us. She has a lot of experience in both areas. So that was terrific today, Kavita.
Thank you.
Thanks, Kavita. I put the code in the chat box. I appreciate you giving us your time to 30 minutes. Everyone have a wonderful weekend, and we'll see you all next Thursday at 12:30. Thank you very much.